Hello and welcome to Georgia Institute of EMS's presentation of post-resuscitation care. Post-resuscitation care presented here at Georgia Institute of EMS will meet the National Registry's requirement for the NCCP national component for your recertification through them. Can also be used in the state of Georgia as continuing education towards your refresher or 40 hours needed to recertify in the state of Georgia as well. And if you're from another state, it could be used there as well. You would just need to contact your state office of EMS. So with that in mind, let's go ahead and get started. So I want to start off by introducing myself. My name is Tom Camplain. I'm the CEO here at Georgia Institute of EMS, and I'll be guiding you through this lesson today. You can contact me at tom@gaiems.com, and you can contact me at 678-561-2368. If you have any questions or concerns, especially arising with this presentation, let us know. We'll be glad to answer your questions and help you in any way we can. So let's look at our objectives for this class and kind of give you an overview of what we're going to be going over today. First off, we're going to look at and try to identify some of the signs and symptoms associated with the ROSC or return of spontaneous circulation. Believe it or not, sometimes it's very difficult to tell if somebody has achieved ROSC, and sometimes we think that the patient has achieved ROSC when in actuality they have not. So sometimes they're still in cardiac arrest and we've stopped doing CPR and compressions on them because we believe that they're in cardiac arrest. And we're going to talk about some things to help us with that as well. We're also going to go over how to effectively manage hemodynamic instability in these patients. We're going to talk about some things like H's and T's as well when we're looking at the possibility of these, the causes of the cardiac arrest. And then we're going to talk about the process of induced hypothermia, and we're going to talk about the pros and cons and what's going on. What are we doing with that, really? I mean, are we doing it? Are we not doing it? What is it? So we're going to talk about that as well a little bit and try to hopefully get you some clarification on that so that whenever you're in the field, you'll be more confident and kind of know what to do in those situations. So let's dive right into it and knock this thing out, okay? So let's look at recognition of ROSC, or, some people may not understand what ROSC is or what it means, but it means return of spontaneous circulation. And one thing I want to really emphasize is that we need to be doing CPR on these patients. CPR is what has been shown to make the biggest impact on these patients. All right, the fewer interruptions, the better, until we have confirmation of ROSC. Okay, so we want to continue CPR until we know for sure that we have ROSC. So what are we going to look for? Okay, so we're looking for signs of life is what we're looking for. If we see signs of life, then we can adequately think or conclude that our patients have had a return of spontaneous circulation. So what are these signs of life and what do they include? Well, of course, it includes a return of a palpable pulse. Now, sometimes in these patients, a palpable pulse can be difficult to find because their blood pressure may be very low and they're really unstable. So it may be very difficult for us to find a pulse, and I just want to go ahead and throw this out there. If you are in doubt if your patient has a pulse, continue CPR. Don't sit there scratching your head thinking, well, I think I feel something. Is that something? If you do not feel a pulse, do CPR. It's not going to do any further harm by doing CPR, and keep doing CPR until we have a good pulse. If that's the only thing. Now, if there's some other signs pointing that they have a pulse, well, then we can stop. And some of those things could be return of organized spontaneous breathing. Now, I want you to remember this, that sometimes you can have patients that do not have a pulse and they have agonal gasping respirations. That's not organized. They're unorganized, okay? So if they have organized, regular, spontaneous breathing, that is a good sign that they have a pulse. But if it's unorganized, uncoordinated, and you cannot feel a palpable pulse, then you should be doing CPR. A big sign that your patient has a pulse is if they are moving. I like to say, hey, if your patient grabs your arms and says, please quit pushing on my chest, well, then that's a good indication that they have a pulse. So you can stop there. But it's probably not going to be that subtle. Now, I've ran some cardiac arrest in the past where I have defibrillated them and they woke up. And they're like, why do you keep kicking me in the chest? And I'm like, dude, you don't even know what's going on. You were dead and we just brought you back. We just fought the Grim Reaper off and brought you back. So, but he came back, oh, my chest is really killing me. Well, yeah, 360 joules just went through it and it's supposed to hurt. So, I guess I could have been just telling you my age there a little bit, but if the patient begins to move around, then that is a good sign that they have a pulse, and then you can reliably start the next phases of your care there. Okay. So let's look at optimizing ventilations. Let's say that we've had our patient, and that patient went from no pulse. We're doing CPR. We've defibrillated them, and we started CPR immediately after that defibrillation. And then at that pulse check, we felt a pulse. And then we started noticing that, hey, they're breathing on their own as well. And heck, maybe he's moving his eyes a little bit. So we've got some good indication there that this patient has regained a pulse. Right now, the time to celebrate is not now because you still got a lot of work to do. And let's look at a few things that we want to do. And one thing I want to touch on here is a little bit about oxygenation and about how much oxygen to give these patients and when to kind of back off the oxygen some and when to give them all the oxygen we can, okay? And I've brought some things up here that the American Heart Association has published, and I've got their link there in the bottom right-hand corner for you. And if you want to get that link, I can email it to you if you want it. It is on the American Heart website under the guidelines. So this is what was published in October 2015, so it's the most current that they have out there. And they tell us to avoid hypoxia in adults with ROSC after cardiac arrest, it is reasonable to use the highest available oxygen concentration until the arterial oxyhemoglobin saturation or the partial pressure of arterial oxygen can be measured. So what does that mean for us as EMS providers in the field? That means that it's okay to continue with the 15 liters of O2. Now, I know out there, and I'm going to talk to you in my next slides about the 94% O2 saturation rules and stuff like that. And you have to really understand that after you get a patient back, all right, they've got a lot of things going on in their body. They may have peripheral vasoconstriction going on. You may not get a good SpO2 reading and so on. And if in doubt, still give them, adequate amounts of oxygen, okay? So here, this is what they also say in October 2015, and this is on their site. When resources are available to titrate the FiO2, remember FiO2 is how much oxygen they are getting in. It's the oxygen that's being delivered to them. And to monitor oxyhemoglobin saturation, which is what we do with SpO2, it's reasonable to decrease the FiO2 when oxyhemoglobin saturation is 100%. Provided the oxyhemoglobin saturation can be maintained at 94% or greater. So what they're telling us here is that if they've got an O2 sat of 94% or more, we can decrease the oxygen as needed. We don't need to overflood them with oxygen. So if we put a pulse ox on them and it's saying 100% and you got them on 15 liters, well then knock it down to 10 liters and see what that does, instead of overflowing. And I saw some people out there put it on 25 liters. Well, knock it back a little bit. And as long as it's 94% or above, we're good. If they're breathing on their own, you may have them on a non-rebreather at 15 liters. maybe knock it down to 10, maybe, or 12, knock it down to 12 and see. That should be fine. And you may take them off and put them on a nasal cannula if it's maintaining 94% or greater. We're okay with that. Now the research is showing that, over-oxygenation can be harmful as well. So that's why they have this guideline in here of 94%. But if your hands are full and there's a chance that they may be hypoxic, do not allow them to become hypoxic, because every incidence of hypoxia decreases their chances of survival and can cause some long-term harm to them. So we don't want to do that. So let's look at ventilation while we're ventilating these patients, because sometimes you may have ROSC back, but they may not be breathing adequately, and you may have to assist their ventilations. So one thing we want to do is avoid hyperventilation or excess ventilation of these patients post-arrest, because whenever we give them too many ventilations, we ventilate them too much, that can cause a buildup of pressure. And I'm going to talk about that in the next slide here in a little bit. And it could make things worse for them. So I'm getting ahead of myself a little bit. Sometimes I get excited. So also too, hyperventilation may cause cerebral vasoconstriction, decreasing vital perfusion. Now, we used to take advantage of this back in the old days. If you had a head injury, we would hyperventilate you. And, we don't really do that anymore unless it's an extreme last resort. So now we want to make sure that we ventilate these patients, somewhere between, around 12. Is good enough, and we're going to monitor. Let's monitor the SpO2, and we're going to talk about end-tidal CO2 as well. We may be monitoring that and just trying to get to the sweet spot in the right area so that these patients are properly perfused, okay? Hyperventilation or overbagging reduces cardiac output, and right now, these patients do not need reduced cardiac output. These are the last patients we need this to happen to. And the reason why it reduces that cardiac output is because that increased ventilation, that hyperventilation that we've been subjecting this patient to, is building up that intrathoracic pressure. And that intrathoracic pressure is going to lower the patient's blood pressure, and their blood pressure gets lowered, it's going to lower cardiac output as well. So here's some more little nuggets, some pearls that the American Heart Association has given us here that I looked up, and let's go over these right quick. So something that I used to teach, and I still do, is that you want to be careful whenever you're using the tube ties or the tube tamers or whatever you call it. If you've got like an ET tube or a combi tube in place on these patients, we want to make sure that whenever we're securing that we're not putting it on so tight that it is potentially obstruction venous return from the brain, which could impair circulation to the brain. Remember, we're trying to conserve as many brain cells as we can. We don't want to do anything that's going to slow down circulation to the brain. So just be careful with that. Be cognizant of that too. Also, elevating the bed of the head, or the bed of the head, the head of the bed at 30 degrees. If tolerated, if you can do it with your patient, that will help with that drainage as well, for getting the blood out of the brain, so more oxygenated and nutrient rich blood can get to the brain as well. It can also help reduce the incidence of cerebral edema and aspiration for the patient as well, and can help long term with pneumonia for this patient as well. Okay, so we want to make sure that we try to position the patient the best we can. Sometimes we can't. We have them attached to backboards, and we do the best we can there. Also, too, if we have an advanced airway in place, we want to use waveform capnography if at all possible. That should be a standard that we're trying to obtain, that we're trying to get to, so that we can ensure that airway is in the proper location, that we can then get real-time feedback of if we are hyperventilating or if we're hypoventilating, or how well our patient's doing. We can get real-time feedback if we gain a pulse too, or if we lose a pulse. We may be able to see these things a lot quicker if we have that waveform capnography in place as well. All right, so just moving on along, let's get on to patient management a little bit. So after we've gotten that ROSC back, we've got our patient back from, where they were, we want to, of course, get somebody to get on a set of vital signs. And we just want to review these briefly here. We want to obtain them frequently. All right. So at least every 3 to 5 minutes. Okay. I mean, you shouldn't go over 5 minutes with these patients because their condition can change so quickly. Before you know it, they could be tanking out or they could be improving. Either way, we need to know. And sometimes you may need to get one, even though I say 3 to 5 minutes, you may need to get one every 60 seconds, or depending on what's going on with the patient. You see a change, you might need to go ahead and get a set of vitals on there as well. So level of consciousness, we want to utilize AFPU and get a good Glasgow Coma Scale. And we want to do that frequently so that we can continue to compare. We can see, are they getting better, are they getting worse, or so on. When you get there, their initial GCS is probably going to be a 3 if you're doing chest compressions, but hopefully you get ROSC. Hopefully that will improve quickly for them. We want to, of course, get a pulse. Carotid versus radial, in these patients, a radial pulse may be very difficult because they may have a lot of vasoconstriction. They may be very hypotensive. It may be hard to find. So carotid may be your best, choice there for that. Like I said, if you're in doubt if they have a pulse, okay, if you can't feel a pulse, they're not moving and they're not breathing, do CPR. CPR is vitally important for these patients. Get a blood pressure, ensure that it's adequate. I mean, adequate and accurate. Okay, we want to do both. A manual one may be better in these patients, especially in the pre-hospital setting. Us moving around, going down the road in the ambulance and stuff, the automatic BP monitors may not give us such a good reading, especially while we're in transport. We want to look at respirations. We want to note any respirations that they have. We want to note their rate, rhythm, and quality if it's present. Remember, those respirations that are not regular and they're sporadic and they really have no rhyme or reason to them, that may be agonal and they may not have a pulse. So don't go by, the old phrase like, if your patient's breathing, they got a pulse, because that may not necessarily be true. Assist the respirations if necessary. Remember the 94% thing. If they're maintaining an SpO2 and 94% or higher, try to titrate that O2 to the best you can. You might need to auscultate them to get a good listen at their breath sounds and get a good rate there. And do not delay CPR to obtain respirations. Okay, we don't want to delay CPR to do anything really. If they need CPR, we need to get on it. With the pulse ox or the SpO2, if you can, continuously monitor that. Even if you're doing with your pre-ROS patients, if you can, put a pulse ox on them. Especially after you get ROSC, you want to continually monitor their SpO2. Just remember, it could be false because their extremities could be cold. They could have vasoconstriction or so on, and you could get a false reading. It may not be accurate. So if it's not accurate, then we're going to, maintain like 10 to 15 liters of oxygen until we know for sure what it is. All right. But remember, if you've got a good reading, you can titrate that oxygen. 94% or higher is what our target is for these patients. End-tidal CO2, if we had the ability to monitor it, and I hope we do because it is a gold standard, our goal is about 35 to 40 there for the end-tidal CO2. And just know that it can be used with patients with or without advanced airways in place. There are adapters out there that you can put on nasal cannulas and so on so that you can get an end-tidal CO2 on patients that are not intubated or not, without a King or combi tube in place. But if you have those in place, the advanced airways, you can utilize them. And they can be there to help you verify that you have a good patent airway in place and help you verify that this patient does have a pulse, they are in ROSC, and if they start to decline at all, you can see that pretty quickly there in your waveform. Also, too, and I hammer this to all my EMT students and advanced EMT students and paramedic students out there as well, is blood glucose. Anybody has altered level of consciousness or an altered mental status, they get a blood glucose. Well, if you're walking in and somebody's doing chest compressions on somebody or if they're unconscious, that's an altered level of consciousness. So get a blood glucose and use that information. If they are hypoglycemic, you get there and they've got a blood sugar of 30, well then, as an advanced EMT, you may need to give them some D50 or so. And if they've got a blood glucose of 600, well then you might need to note that so that, treatment can be started whenever they get to the appropriate facility as well. We need to get vascular access. We need to ensure that we have it, and we can do that in one of two ways. We can either get an IV or an IO. Adult IOs are very reliable now. Pediatric IOs are very reliable as well. And just so that I can note that everything I'm talking about, please know that this counts for pediatric and adults. This is not just specific to adults or whatever. So all this information I'm giving you relies to the pediatric patients as well. So we need to get an IV or IO access and make sure that it's good and patent so that we can administer medications if we need to, or if a paramedic's jumping on board and they have a route, or when you get to the hospital has a route, or you have a route for some of the medications you can give, or you may need to give a fluid bolus based on their hemodynamic status. If their blood pressure shows that they need a fluid bolus, you might need to give them one. And I get ahead of myself sometimes. So you want to monitor the patient's overall status, looking at all those vital signs, okay, and their history. Get a good history. Get a good assessment on these patients. And then with all that information, establish your priorities for treatment based on these findings. And we're going to talk about a few other things. We want to get H's and T's as well on these patients, and we'll talk about that as well. You want to maintain a blood pressure of at least 90, so if you need to, you may need to utilize a fluid bolus if necessary. But be careful. We don't want to try to get these patients to a normal blood pressure level. We don't want the blood pressure to get too high, because too high blood pressure could cause problems. For instance, let's say they're in cardiac arrest because maybe they had an internal bleed for some reason. Well, maybe the low perfusion status or us doing CPR slowed things down enough for them to form a clot, and that bleeding stopped. Well, then here you come infusing 2 liters of fluids and raise their blood pressure from 80 all the way up to 160, and you just wash that clot out and stuff. Another thing is these fluids do not transport oxygen, so giving them a lot of fluids and diluting the blood that they have there can cause other issues that we don't want to do. So maintaining a blood pressure around somewhere between 90 and 100 is very adequate for these patients, especially if they're laying on their back and they're laying down, and we're going to be doing most of the work for them right now. So one thing you need to really understand and review is the H's and T's. And I've got them listed here, and they are hypoglycemia, hypovolemia, hypoxia, hydrogen ions, hyperkalemia or hypokalemia, and hypothermia. Okay? Tablets or toxins, tamponade, cardiac, tension pneumothorax, thrombosis, thromboembolism, and trauma. You need to memorize these, because if there's anything you can do to help prevent them from going back into cardiac arrest, you want to do that. Like the hypoglycemia, you took that blood glucose, they're hypoglycemic, you want to get some sugar on board. If they're hypovolemic, we might need to get some volume on there. If they're hypoxic, we need to get some oxygen to them. Hydrogen ions, if they're acidotic, we might need to ensure that we have a patent airway and we're ventilating them well, and we have given them some fluids. Hypothermia, we may or may not want to keep them warm. You may want to contact your protocol on that, especially on a ROSC. They may want you to keep them hypothermic, and we're going to talk about that a little bit later. Tablets and toxins, you may be given some Narcan. The opiates are a huge deal right now out there. We have cardiac tamponade, tension pneumothorax, thrombosis, thromboembolism, and trauma. All those things, if there's something you can do about it, then you should. And transport these patients to a facility that can properly manage them. If the patient might need a cardiac catheterization, send them there. If they're a Ross patient and there's one facility that's not doing a great job at doing the hypothermia protocol and there is another that is, well, then you may want to transport them to the facility that has those things in place. And we're going to talk about that hypothermia here. Let's talk about targeted temperature management just a little bit. Some of the benefits that it has is it increases favorable neurological outcomes, especially those that that were in VFib and we had a return of spontaneous circulation, and they're just neurologically not coming back around like we would hope, and it has benefited them greatly. It reduces cell damage and death and slows down the cellular metabolism until we can get them to an appropriate facility where they can be managed appropriately. The procedure, this is accomplished by applying cold packs to the axilla, the groin, and the neck, and can also be utilized, or can be done by utilizing chilled IV fluids. However, in the pre-hospital setting, the results aren't that great for us. Now, it's great in hospital. And one thing you got to realize that in the hospital, there's a lot of people managing these patients. There's a lot of monitors and a lot of things that the physician can utilize to properly manage this patient. We don't have that in the pre-hospital setting. We just need to get them to the hospital so that they can get to that. Now, the 2015 AHI guidelines specifically recommend against the routine pre-hospital cooling of patients with ROSC because the rapid infusion of cold IV fluids has shown to have adverse effects, especially in the pre-hospital setting. So cooling them down in a controlled environment at a controlled rate is much better. And that's something we can't do in the pre-hospital setting very well. So I know we're talking a lot about this hypothermia stuff and it works great, but in the pre-hospital setting, it's just not there for us right now. So let's look at systems of care. So one thing I need you to really understand is that within the first 24 hours, that's when most deaths occur after ROSC. So just because you get a ROSC in the field doesn't mean that they're out of the risk factors right yet. So they still have that first 24 hours to get through. And that first 24 hours can be very difficult. So you have tools available to you that could greatly help these patients. And that's based on the choices you make of where to take them, okay? And you need to take them to an appropriate facility that can manage them. And these appropriate facilities may include STEMI or PCI centers, cardiac centers, or therapeutic hypothermia centers. These are hospitals or centers that are certified with specially trained people on staff ready to take care of these patients in a moment to the best of their ability. So in conclusion, it's important for us to be able to recognize ROSC. We want to look at the patient. We want to see, do they have a pulse? Are they breathing regularly? You have regular respirations that are purposeful respirations. And are they moving? Do they have movement? If they're moving around and stuff and they have a pulse and they've got respiration, that's a good chance that they have ROSC. We want to optimize their ventilation and oxygenation. Remember 94% or above. Do not hyperventilate the patients. We want to closely monitor the patients. Utilize SpO2. Utilize capnography if possible and stuff. Closely monitor them. We also want to think about utilizing EKG. As an advanced EMT, you can attach a 12-lead EKG and transmit it ahead, and that may be very beneficial for the patient. Know about targeted hypothermia. Know that in the pre-hospital setting, it's not recommended for us at this moment, but who knows, things may change later on. It needs to be in a more controlled atmosphere where they can be gradually brought to the correct temperature and not cooled too much or not cooled too quickly and stuff. And we can do that by transporting them to an appropriate facility that has the equipment and the trained and ready personnel to adequately manage that patient at a moment's notice. And, luckily, most facilities I think in the Atlanta area are there. But sometimes they go down. Sometimes you know they may have a situation where they have too many patients, and you may need to transport. You may need to be diverted to another facility. That's why it's important for you to know your facilities in your area, know their capabilities, and know their status when you come on shift. All right. Well, we made it through this presentation once again. My name is Tom Camplain. This is my contact information. Please feel free to contact us at any time. And if you have any questions or anything about post-resuscitative care, please feel free to give me an email. Give me you can call the school, and if I'm available, I'll be glad to help you out. But you can reach me there via email as well, and or you can call us, and I will get back in touch with you. I promise. So thank you so very much for your time, and I hope this was beneficial. And we'll see you next time. Thank you very much.